Now, I can see a screen, but I can't see it moving. So can anyone tell me if the screen is moving? Can anyone see? You can see it. Okay, so you see antipsychotics and physical health in first episode, Psychosis. I'm so happy to be talking to your network because I've known about Esteem for some time, but hearing that you're actually expanding into other areas, I think is very exciting, and I'm delighted to support you in any way I can. Rachel's told you a little bit about myself. I was lucky enough to, as a trainee in psychiatry, to bag a job in early intervention. And Max Birchwood, there you will all know, was very pivotal in my I suppose falling in love with early intervention, really, and Professor Rachel Upthegrove also was one of my medical mentors. And I think any of us who've worked in early intervention will know that it's very hard to work anywhere else in psychiatry once you've experienced the kind of the ethos and the values of the care in early intervention. So I'm, a big advocate of early intervention, and I was lucky enough to be asked to join, as you said, Rachel, some of the pioneers of early intervention in writing the book Recovering from the First Episode of Psychosis, and this was really a kind of looking at recovery being so much more than symptomatic recovery, that there's no point in having symptomatic recovery per se if there's no functional or social recovery or personal recovery. And we felt it was really important to write it with various team members from early intervention, so from the medical side, psychologist side, and nursing side, to give an integrated approach, and really wrote it with people like you in mind, working in early intervention. So it's very much evidence-based with a sort of practical and pragmatic approach to doing early intervention in first episode Psychosis. And one of the chapters that I wrote was about prescribing and physical health, and that's really what I sort of based my talk on. I'm not an academic. You would know that if you saw me pulling my hair out trying to write this book. It took about 3 years to write, so it was a real labour of love, but certainly worth it in the end. And I think what I really learned was how important it is to sort of distill all the evidence, because there's so many different trials that, and we're given information from trials that sometimes isn't accurate. And for me, it was really important looking particularly at the antipsychotics. What does the evidence actually tell us, and how do we actually appraise that? So hopefully this is sort of a balanced approach looking at prescribing and physical health, which is so important. And I've called the talk The Good, the Bad and the Ugly. And I'm going to start off by putting it out there that antipsychotics are actually good. They get a bad press, but actually from their discovery in the 1950s, it sort of heralded a new era for the treatment of psychosis and schizophrenia. And so we need to remind ourselves of the good that antipsychotics do. And what I'm going to be focusing on is why they work, how they work. How do those of us who prescribe, how do we choose which antipsychotic will suit our patients? What's the role of clozapine in treating first episode psychosis? Big issue is around concordance in our patient group, and how can we improve that? How long do we tell our patients that they should be on medication for? And the huge issue of the deficit syndrome, how do we actually treat that? Are there any medications that can help with that? The bad is really focusing on our patients' poor physical health, and what can we do about that? We also need to look at the side effects. So antipsychotics have a lot of positives, but they also do have side effects. How can we as a team help our patients counter those side effects? And then I'm just going to finish off with the ugly. Many of you will know about the anti-psychiatry movement, but for those of you who don't, just going to briefly talk about how we address that, and just to the importance of being aware of it. And then any of us working in early intervention also know the difficulty, the obstacles that cannabis and substance misuse play in patients' recovery from first episode psychosis. So that's what I'm planning to cover. I think, so you said about 50 minutes, so I'm probably going to aim to finish at around just after 10:30, 10:35. Hopefully I won't go over. Okay, so let's start off about the treatment goals of antipsychotics. Now, I am a biological psychiatrist, but I'm a fierce advocate of medication being part of a full biopsychosocial treatment package. So as I say, there's no point in just treating symptoms without helping people make that functional and sort of personal recovery. But they often are the first port of call of treatment of psychosis, and the sort of the foundation to for recovery for people to engage in psychosocial treatments. So what are our aims in using antipsychotics? So the first aim, I think, is reduction of distress. So our patients will come to us when they're referred to us early intervention, and many of them are in a state of high agitation and hypervigilance, suspicion, don't want to be with us, don't want to be seeing us usually. And challenging the myth that antipsychotics take weeks to work. Actually, usually in the matter of days, patients will start to feel better. So maybe when they're not sleeping, they're highly agitated, this agitation and distress will start to reduce. And that enhances then our ability to develop a therapeutic relationship with them. So that, to me, is at the first sort of main aim of the antipsychotics. Following this, then, we're looking for symptomatic reduction and ideally full symptomatic remission. And they're really effective at that. So if we're talking about a significant improvement in the PANSS scale, which is a positive and negative symptom scale of greater than 20%, we know that around between 75 and 80% of patients within weeks will experience a significant reduction in symptoms. And when we're thinking about symptomatic remission, just a wee word of warning is not to assume that patients would like to get rid of their symptoms altogether. I always remember one of my patients who was very isolated, didn't have any family members near him or friends, and he had one persecutory voice called Colin. And Colin would say terrible things to him, tell him he'd be better off dead, etc. And as we increased his antipsychotic medication, Colin's voice became quieter, less intensity, reduced frequency. And then we finally increased his antipsychotics up to the point that Colin had gone away completely. And on the day that he didn't hear Colin was the day that he tried to take his life, thankfully unsuccessfully. And I asked him what that was about. And he said, even though Colin is persecutory, actually he was my only other person in my life. And the loneliness was worse than hearing the negativity that Colin, would speak to me. So to me, it was a real learning lesson in asking our patients, do they want to complete, if they're hearing persecutory voices, what is their goal? Do they want to get rid of them completely? Or do they just want to have some control over them, maybe lessen them in intensity and gain some control over them? So we want symptom reduction and ideally remission if that is what patients want. Another huge positive that antipsychotics give us is relapse prevention. So the evidence tells us that if patients stop antipsychotic medication, their risk of relapse in that first year is 67%. If they remain on medication, that relapse is significantly less at 27%. So really important. message to give to patients, because they often feel that I don't need this medication anymore, the psychosis has gone, but actually it's really important to prevent further relapse, because we know each subsequent relapse can cause further morbidity and be more difficult to treat. And then finally, and a really important one, and I think one that people often forget, is the risk minimization, not only to self, but to others. And just want to explore that in a bit more detail. So we know that the lifetime risk of suicide from schizophrenia and psychosis is around 6%. Now, a really interesting observational study that Yari Tihun did of over 2,000 patients with first episode psychosis found that those who were treated had very low mortality. There was only one death from suicide on patients who were on antipsychotics, compared to 75 deaths. 26 of which were reported suicide for those patients who were untreated. And they were a smaller cohort than the patients who were treated. So it shows how risky untreated psychosis actually is to self. And although thankfully homicide is very rare, if it does happen, it is much more likely to happen in the untreated psychosis phase. Antipsychotics also significantly reduce the frequency of aggressive acts, and often those aggressive acts are directed towards family members. So when we're looking at principles of starting antipsychotics, and this is true for all patients and for all members of the team, is taking a collaborative approach with patients. What do they want? What do they want to get out of treatment with medication? And giving them a choice, if they're able to, if they're well enough to be able to have that sort of informed decision making, but giving them a choice based often on side effect profile, giving them as much information as possible at the appropriate time. So when somebody first comes, they're not going to be able to take in a lot of information if they're highly distressed. But the more information they're given about why the antipsychotics are working, the more likely they are going to be concordant. Having a flexible approach is hugely important. We know that with early intervention, flexibility in how we manage patients with patient-centered care is key to that therapeutic relationship. And that might mean that if somebody isn't particularly risky, but they are experiencing psychotic symptoms, but they're just not ready to start antipsychotics, we might need to just have patience and give them time to build up that relationship before they're able to start taking the medication. Clearly, it's different if they are putting themselves or others at risk. And creativity, I think, is important when it comes to any of our treatments, whether it's psychological or medication or social treatments, and that's really, really important. I remember one of my patients was had a lot of delusions about colours and believed that the colour red was the only safe colour, and would only eat red foods, so tomatoes, strawberries, etc. And her care coordinator creatively used red food dye to colour her tablets, so she would take her antipsychotic medication. So that's a good example of creativity. So how do they work? And I think this is really important, is to explain to our patients how they work. Now, we know that dopamine is one of the this is from the neurobiological perspective. Dopamine does play a part in the etiology of psychosis. And we know that patients who are experiencing psychosis, we can see with neuroimaging that there's activity in the mesolimbic system. And the theory is that patients who are vulnerable to psychosis have a sensitivity to dopamine and an increased production of dopamine if they're in stressful situations. So we explain to patients who we feel can understand this sort of neurobiological theory that the antipsychotics work by dampening down dopamine and therefore dampening down the hallucinations and delusions. Many patients aren't really going to be able to work with that type of theory, and so many of us use that stress vulnerability model, talking about the brain when we're really stressed, our brains don't work so well, and they can misfire, and they can make us misperceive things. So sort of using normalization and an explanatory model with the stress vulnerability. and talk about how toxic stress can be to the brain and the rest of the body, our immune system. But stress in the brain can create misperceptions, jumping to the wrong conclusions, etc. So using those theories can be really, really helpful. And you may want to start off using a theory of stress and then move more into dopamine as they want to understand better why antipsychotics work. And another thing that I use a lot is metaphors. And I use the sponge metaphor quite a lot. So where a sponge soaks up water, I will talk about antipsychotics are kind of like a sponge soaking up the stress in the brain, so our brains work better. You may want to use the metaphor of a brake, that antipsychotics can put brake on the distress and the psychotic symptoms. I often talk about a helmet, why you're taking antipsychotics. And I talk about the neuroprotective effects of antipsychotics. So where you wouldn't dream of getting on a motorbike without a helmet to protect your brain, that's what antipsychotics are doing. They're protecting your brain from further relapses and further, toxicity of that stress can cause. When we're talking about relapse prevention, sometimes I would use the metaphor of preventing something happening in the same way that you might take the oral contraceptive pill to prevent getting pregnant. You're taking the antipsychotic to prevent a further episode of relapse. So metaphors, I think, often are a good way of patients understanding better why antipsychotics work. But it is so important to help explain it. Now, people often ask, how do you know which antipsychotic patient to start somebody on? And I think it's important to first look at the evidence. So we've got these large randomized controlled trials. The large one in America was Katie, which was over 2,000 patients, and a similar one in the UK was the Cutlass trial. And these were patients with established schizophrenia, comparing first generation, the older antipsychotics, with the newer second generation antipsychotics. And the UFES trial, which is probably the one that's most relevant to us, was the European first episode schizophrenia trial. And so looking at the evidence of all these trials, there's four main things to come out of this. So the first thing is that the first generation, the older antipsychotics and the newer antipsychotics have equal efficacy in treating positive symptoms. So when the second generation antipsychotics, when they were sold as being more effective, actually that was overstated. They're equally effective. But what is different is that the second generation antipsychotics are better tolerated in the first episode population. And that is why they're first line, should be first line treatment for our patients. What also came out with all these trials was that there's a really high discontinuation rate, 75% for all antipsychotics, but the discontinuation rate was higher for the first episode. And the other interesting factor that came out was that clozapine consistently outperforms other antipsychotics, and we'll come on to talk about clozapine in a bit. So therefore, when you're deciding which antipsychotic to start with, you're really thinking about the side effect profile. So just to rehearse that the first generation antipsychotics work primarily through blocking dopamine. So they're effective, but they also cause these sort of Parkinsonian side effects, the extrapyramidal side effects. So many of your patients are on these, you might notice they have reduced arm swing, tremor, they might suffer from rigidity, dystonias, which can be very painful and unpleasant. The side effect we really want to avoid is tardive dyskinesia, because that can be irreversible. So that's sort of involuntary orofacial movements. Akathisia, that inner restlessness, is a really troublesome side effect that many of your patients, I'm sure you will know, have experienced, and it's this inner restlessness that actually is really quite uncomfortable. And then also dopamine blockade in the anterior pituitary gland can raise prolactin, and hyperprolactinemia can cause some difficulties, which we'll look at later. And then the newer generation of antipsychotics, we need to know that they can cause metabolic syndrome. And the four main parts of metabolic syndrome are obesity, so BMI over 30, high blood pressure, dyslipidemia, So high cholesterol and lipids and insulin resistance, which can lead on to diabetes. So very important that we monitor for these and prevent the development of metabolic syndrome. And then again, thinking about the side effects, weight gain is one of the most annoying and difficult side effects for patients. And the worst perpetrator is actually olanzapine. Clozapine comes a close second, but olanzapine really does pile on the pounds for a patient. So be aware of that. And the ones, the sort of newer generation or third generation antipsychotics like aripiprazole or lurasidone or ziprasidone, that causes the least weight gain, as does amisulpride and the older, the first generation antipsychotics. Another common side effect is sedation. Clozapine in the initial stages is the most sedative of all antipsychotics, and it can take some weeks for that patients to sort of tolerate the sedation, which does eventually wear off. Looking again at the aripiprazole and amisulpride, the least sedative. Clopixol is one of the older generation antipsychotics, and for patients, in patients, it's often used because it's one of the best first generation at sort of reducing distress and anxiety and agitation. Okay, and then finally the hyperprolactinemia. So the more dopamine blockade, the more hyperprolactinemia you're going to get. So that'll be first generation. And risperidone is classed as a second generation antipsychotics, but it has a lot of similarities with first generation. It has more dopamine blockade, and therefore you will notice that your patients on risperidone are more likely to have extrapyramidal side effects at higher doses. So just to be aware of that. Okay, so when it comes to prescribing, be aware of the side effects, and your choice will depend on side effects. If you can discuss it with patients which they prefer, do you want something that you may cause you to gain weight, but you'll feel better on it? You'll probably notice that you're sleeping better, etc., compared to maybe one that has less sedation and less weight gain. So try to have that honest discussion with patients around side effects. Now, I would say that olanzapine, we know the studies show it is one of the best tolerated antipsychotics. So if your patient has lost weight through a long prodromal period or long duration of untreated psychosis, and they aren't sleeping and they are highly agitated, then olanzapine would probably be a safe bet, probably be a good one to start on. But if they are overweight or there's a family history of diabetes, you want to avoid it. Risperidone is a good starter if somebody is overweight, but as I've said, watch their extrapyramidal side effects, particularly at higher doses with risperidone. I like quetiapine. It's got a large dosing window, so can be used. You can use small doses during the day, maybe 25 milligrams twice a day in the morning and afternoon, and then a higher dose in the evening, which is a more sort of antipsychotic dose. And if there are affective features, then quetiapine has been shown to be advantageous. And the newer generation of antipsychotics, like aripiprazole, they are really good because they're low with the side effect profile. But many of us find that using aripiprazole in the acute stages, if someone is highly agitated, the distress tends not to come down so quickly. So just to be aware of that. Okay. Amisulpride is well tolerated and it is low on weight gain, but it is obviously does have more extrapyramidal side effects, so it is more like one of the first generation antipsychotics. So those are just some of my pragmatic tips. Those of you who prescribe antipsychotics, you will all have your own personal choices. But I guess this is, I've been working as a consultant in early intervention for around 15 years, and these are some of the pragmatic sort of tips that I would suggest. But really be interested to hear some of your, if any of you have got any questions about that or any of your prescribing suggestions, would be very welcome afterwards. It's really important, I think, to share those. Okay, so we've looked at how do antipsychotics work, why they work. We've looked at why we use them, and we've looked on how do we choose which antipsychotic with the patient. But I do want to really focus particularly on clozapine. So we know that between 17 and 25% of our patients will not have a symptomatic remission, and they're what we would call treatment resistance if they've tried 2 different antipsychotics. And we know that clozapine has a number of advantages. So for those patients with treatment resistance, 75% show significant improvement on clozapine. We also know through these trials that it's one of the better tolerated antipsychotics, along with olanzapine. And it reduces hospitalization and the use of the Mental Health Act. It does reduce impulsivity, aggression, and suicidality, a significant reduction of 83%. So that's a really important statistic. It's one of the only antipsychotics that's shown to improve cognition, and therefore employment rates improve. And it is cost effective, it does say. Well, that's an older study, so it will be higher with inflation. But it was estimated that it was saving the UK around £8.3 million for those reasons. But we also know that it's underutilised. So in the 2014 National Schizophrenia Audit, it was shown that many patients are put on a variety of different antipsychotics and not clozapine, and that those who are put on clozapine, there's often 4 to 7 years delay before doing so. It could have been done much earlier. So why is that? Why does there seem to be a reticence to prescribe clozapine given its benefits? And I was part of an audit of over 250 consultant psychiatrists, asking them if they prescribe clozapine, and if they don't, what are the reasons, or what are their reasons for delaying the prescribing of clozapine? And you won't be surprised with what they reported. So the first reason people were saying was that it has a lot of side effects. We do know that clozapine has a very wide activity over different receptors, and therefore does have a number of different side effects. And neutropenia being the big one. So the need for weekly blood tests for those first 18 weeks, which eventually reduces to monthly. But that is, that is a pain for patients. A lot of them just said it was just resource-ish. We didn't have enough team. It's really difficult to get a patient admitted to hospital to start clozapine. And so that is difficult. You have to really be prepared to do home initiation. And then a lot of consultants were saying that we don't prescribe it enough, so it is down to underconfidence. So what I would say is, like, I'm aware that your early intervention service is set up as a 2-year service, and so I would say that's particularly important for you in Scotland, is that don't miss the boat with clozapine, because if after they're discharged from early intervention, their chances of getting onto clozapine are less likely if they're in the community mental health team. So identify them quickly. And we know that actually, if somebody hasn't responded to an antipsychotic after 6 weeks, they're probably not going to respond to that antipsychotic. So it's worth changing to a different antipsychotic. So really, in the space of about 3 months, we should know who is treatment resistant, who will benefit from clozapine. So make sure you've got a process to identify those patients as early as possible who are treatment resistant, and then develop a good home initiation policy. And what's really our key is having good physical health monitoring because of the side effects, and we'll come on and talk about those when we're talking about physical health. Okay, then. The big issue is around concordance. So we know up to about 75% of our patients in early intervention are going to be non-concordant with the medication in the first year. And that is an issue because that does, we know that stopping antipsychotics is the single most predictive factor for relapse. So how can we improve concordance? And what's really important is, I think, if they're invested in the decision around what medication they're going to start on, then that is going to help concordance. But for your care coordinators and the medics, make sure you do a regular review of the side effects. And if they're getting side effects, make sure they do get a medication review and tailor that medication accordingly, because one of the commonest reasons for stopping medication is due to side effects. And compliance aids can be really, really helpful. Simple things like also maybe setting an alarm on their phone if they're taking it at night or in the morning, sort of building up that habit of remembering to take medication. But a really important factor is thinking about the role of depots in early intervention. When I started in early intervention many years ago, depots were kind of seen as unfavorable. They were seen as, really for patients who've got more chronic illness. And this was backed up by an audit in 2016 of 7 early intervention sites, and found that actually depots accounted for less than 1% of antipsychotic prescriptions. And it is quite surprising given the evidence that long-acting injections, depots, have the highest rate of relapse prevention alongside clozapine. And they're also linked with lower rates of hospitalization. And that is just because obviously patients are concordant with their medication when they're on a depot. So again, what I would advise you is to look at your patients, try to work out how many of them have got erratic concordance with oral medication. And it probably will be the majority of them, and then assess whether they're prepared to take a depot. Now, if somebody has got a needle phobia, you may want to consider a medication called penfluridol, and I'm sure many of you won't have heard of that. Penfluridol actually is a first-generation antipsychotic, and it has a very long half-life, so it's absorbed and deposited in fatty tissue and then sort of released gradually. And it will half-life is between 4 and 7 days, so it can be given orally once a week under supervision. It's off license, so you need a consultant to prescribe it, but it can be very beneficial for patients who have got per concordance but are needle phobic. Okay, so your patients will ask you, how long do I need to be on these wretched tablets for, or injections? And again, the evidence would show us high relapse rate. We know it's 67%, not just in the first year, it's 67% for the 12 months at any time after stopping antipsychotics. But that doesn't mean you need to be on antipsychotics for life. And I think the important thing is to look at so in England we use NICE recommendations, and their recommendations are to continue with antipsychotics for between 1 and 2 years. And Mesifus went somewhere in between, they said around 18 months of continued antipsychotic medication following recovery from first episode of psychosis. So what's really important, I think, is to sit with the patient and work out when, rather than giving some spurious date, is actually say, if you want to come off the antipsychotic medication, then we're going to do it in such and such a date. So if I see somebody today and they've made a really good recovery and they're not taking they're not using drugs, and there's re-entry in the employment sector, supportive family, etc., etc., they're one of the people who you may want to start looking at taking them off antipsychotics in 12 months' time. So I may say, okay, next August, let's look at gradually taking you off, weaning you off the antipsychotic. However, if you want to come off it in 12 months' time, you've got to ensure you stay off the cannabis. You've got to show me that you're making a good functional recovery, etc., etc. And also complete a relapse prevention plan, because you will know that those are really, really helpful in helping patients identify the early warning signs of relapse, and looking at what they can do to actually prevent relapse of psychosis. So those are the sort of conditions. If they are still using cannabis and they're not, they're quite isolated and they don't maybe have a supportive family or friends around them, you'll want to be pushing that more towards the 24 months. Okay, and when you do try to wean somebody off antipsychotics, my advice is do it conservatively. So I will usually say, if somebody is on 10 milligrams of olanzapine, I would suggest we reduce it by 2.5 milligrams every 3 months and come back every 3 months for a review, which will allow time to see you know, are there any breakthrough psychotic symptoms, in which case we slow down the downward titration. We may even decide to put it back up again. And so we need to warn patients that that is something that may well happen. One of the risks is they might get some psychotic breakthrough symptoms as we reduce it. There's a lot of sort of debate about using a clinical staging model, much in the same way that maybe cancer is staged. So, you know, the higher stage of psychosis, you would be more likely to not take them off their antipsychotic medication. But people who've got a good prognosis, maybe acute onset, who've responded very quickly to medication, they're back in education or training, would have a more favourable prognosis, and they're the ones who are more likely to, you would be able to start taking them off their antipsychotics in 12 months. Again, what I would say is if you're going to do that, you need to do it when they're in early intervention. And I guess it's more pressure on you because you're a 2-year service. But if they're going to have a relapse, you want it to happen under early intervention, because we're good at picking up relapse and empowering people in managing that relapse, and, you know, better understanding that the role that antipsychotics can play in preventing relapse. Okay, and then I just want to briefly mention deficit syndrome, because psychosis is so much more than just obviously the positive, you know, what we call the positive symptoms of psychosis, the delusions and hallucinations. The deficit syndromes that we know often as the negative symptoms, lack of energy and drive and motivation, but don't forget the cognitive deficits. People often forget to ask about those, and they are often sort of poor short-term memory, difficulties planning, processing speed, concentration. And they really are very, very difficult for patients. So when you're assessing somebody as they're making that recovery from this sort of symptomatic recovery, make sure you assess them for symptoms of the deficit syndrome. And what to do if they do have deficit syndrome? Well, first thing is consider, have we got their dose of antipsychotic right? Are these symptoms secondary to maybe only partially treated psychosis, where we might need to increase the antipsychotic? Or are these symptoms partly because their antipsychotic dose is too high and they're too sedated? So have a think about that. You might want to alter the dose. And if you think if it's the symptoms are due to sedation, then maybe change them if they're on a sedative antipsychotic to a less sedative one. But also remember, depression, post-psychotic depression, is very, very common and is treatable. So you do need to remember to screen for that. Now, looking at, are there any medications for deficit symptoms if it's not depression or due to the antipsychotic medication not being correct? And the bad news is there are no medications. Lots of trials looking at sort of stimulants to treat sort of cognitive dysfunction, or anticholinesterase inhibitors, you know, the anti-dementia medications, thinking about the inflammatory sort of theories around psychosis and schizophrenia. Could antibiotics work? All, you know, there's some positives in some small trials, but they weren't replicated in large randomized control trials. So we can't use medications, therefore, well, apart from clozapine, which I've mentioned, but therefore that reinforces the need for the psychosocial interventions. And remember to talk about cognitive remediation with our patients, sort of directing them to maybe apps on their phone, brain gym apps that help maybe their short-term memory, their processing speed, etc. So often they get forgetted about these deficit symptoms, but they're really, really important that we pick up on these and think about how we can help our patients, and particularly looking at psychosocial interventions. And just a quickie about post-psychotic depression, it does affect about half our patients after first episode psychosis, and it is associated with poor prognosis and suicide. It can be hard to differentiate between just the negative symptoms. I think if you're looking at anhedonia, that's total loss of pleasure, a feeling of hopelessness, tearfulness, suicidality, that's more in keeping with the post-psychotic depression rather than negative symptoms. And so we know that antipsychotics are just as effective in post-psychotic depression as any depression. So think about you know, discussing it with patients about starting an antidepressant. And there I'm involved in sort of an EDUP study, which is Rachel Upthegrove, actually, she is the chief investigator for that. And that's looking at, you know, should SSRIs be prescribed as a preventative therapy to prevent post-psychotic depression. Okay, so that's the sort of antipsychotics, prescribing some of the benefits, why they work, how they work, looking at clozapine, looking at depots, concordance, etc. Now we're going to move on to physical health, because this is such a huge subject. And you will know that our patients will have a reduced life expectancy of between 15 and 20 years, which is a huge health disparity and actually scandalous. What are we doing to prevent that? Are we doing enough? And early intervention needs to not just be about early intervention in psychosis. I think we need to think about that we are early intervention for physical health difficulties as well, and early intervention into intervening early if they're developing side effects to the medication. Really, really important. Why do our patients have reduced life expectancy? Well, it's primarily through cardiovascular risks, and that can be lifestyle. Smoking is a big part of that, sedentary lifestyle, diet, etc. But not only our patients have, you know, the cardiovascular risk, there's other associated difficulties that our patients have unrelated to confounders. So we know that patients with psychosis and schizophrenia have a high risk of certain cancers, and they also have a higher risk, independent risk of developing diabetes, let alone due to the antipsychotics. That's an independent risk. Given that, we also know that there's a poor access to healthcare, that patients are often, their physical symptoms are ignored because they are under mental health care, and seen that their symptoms are all related to their mental health. And put this in red because I want to speak to all the prescribers and well, all the sort of care coordinators, anyone working in early intervention, is don't fall foul of valence, collusion of anonymity. And what I mean by that is believing that the GP is going to pick up if there's any physical health problems. The GP will often assume that's the psychiatrist or the mental health team that are going to pick up in any physical health problems. I remember a friend of mine who's a really fantastic GP. He was seeing a patient with schizophrenia for a long time, and she developed diabetes and she became, you know, obese, and he assumed the psychiatrist was monitoring her weight, etc. And then he realized she was on olanzapine and spoke to me about it. And I said, you know, she needs to get off olanzapine. Have you talked to the psychiatrist about it? And when he picked up the phone and talked to the psychiatrist, she was quite shocked that he hadn't actually thought about that himself. And I think that's the issue, is that don't assume the GP is going to be monitoring the physical health, and GPs need to not assume that psychiatrists are, but we should be definitely monitoring the physical health. Again, just rehearse. These are the really important things for us to monitor as teams. So their weight, blood pressure, their lipids, and their sugar control. So Helen Lester was a GP in Birmingham who was very, very interested in the physical health of patients with severe mental illness. And she worked very closely with early intervention, and she was involved in a lot of studies in early intervention. And she looked to develop this cardiometabolic health resource, which we call the Lester tool, to help GPs and psychiatrists pick up on the really important points. So the 6 parameters are smoking and lifestyle, weight, body mass index, the blood pressure, sugar glucose regulation, and lipids. So those 6 parameters. And she developed this back in 2012. And unfortunately, she died not long after that. So we would expect that to have made a bit of a difference. But let's look at the National Audit of Schizophrenia in 2014. And it showed that only a third, or less than a third, of patients had their physical health monitored appropriately. And actually, when you delve into that, looking at those 6 parameters, it was much less than that. It was less than 20% actually had all those parameters monitored. only about half of the patients had a recorded weight at any point in their treatment. Really shocking. And again, another shocking statistic was for those patients where there was an abnormal glucose identified, either in the pre-diabetic range or the diabetic range, 64% of those patients, it was ignored, nothing was done about it. So you can see why patients go on to develop diabetes if it's not picked up early. So what can make a difference? Well, what I would say has made a difference to the physical health of our patients is the National Clinical Audit of Psychosis, and that's for all early intervention teams in England and in Wales. So unfortunately, it doesn't cover Scotland. And this was a 5-year improvement programme for early intervention services. So they look at our access and waiting time targets, setting targets. We need 80% of the patients to be treated within 2 weeks of referral. We looked at psychological treatments. There's targets for that, targets for prescribing, identifying treatment resistance and offering clozapine. And physical health monitoring plays a huge part in the targets. And the targets are tough. The target is that we have to reach 80% of screening and 80% of those 6 parameters for intervening if there's an abnormality. And you don't, even if you've screened for 5 of the parameters, but have maybe not reported whether they're smokers, then you lose a point. So you have to, all those 6 parameters have to be documented in order for you to gain the point. So looking back at the baseline in 2014 was 33%, although actually it is lower than that. It's more like 20%. So screening for all 6 parameters. So the first audit was in 2018. So 64% of patients in all the early intervention teams in England and Wales had all 6 parameters screened for. And 55% had interventions offered for any abnormalities. And you can see the improvement in the space of 3 years. So that audit in itself seems to be working. So we've got up to 80% of our patients are screened, which is brilliant, and 71% intervention. And hopefully next year, we will show that interventions also go up to 80%. So if somebody is developing diabetes or dyslipidemia, we'll pick it up early. So what do you need if you're setting up an early intervention team? I think you need someone to lead on this. Physical health is really, really important. You need to get equipment, so scales, BMI and height to interpret the BMI, simple sphygmometer, blood tests, an ECG machine. And that is all you need. And then somebody to lead on that those physical health assessments. So on our team, we have got a physical health lead, and we also, my junior doctor will also help with the physical health assessments and screening. And it needs to be very well documented. So interventions. Now, we're very good at thinking about risk in early intervention, risk to self and risk to others. But are we really thinking about risk to self with physical health? And we know that our patients smoke more than the average population. So it's about 14% in the UK. I think it's about just over 15% in Scotland. 60% of patients at first presentation are smokers. And so one of the things that we can do that can really, really significantly reduce their risk is to help them quit smoking and to incentivize them. And to know that actually smoking, if people can get off smoking, it's another incentive is that they will be able to reduce their antipsychotic as well. But it's really around improving their life expectancy and quality of life. So make sure you have access to smoking cessation services, access to be able to prescribe nicotine replacement therapy. Weight gain, it's one of the huge obstacles to recovery for a lot of our patients, and 60% of our patients gain weight, and it's usually rapid in those first few months. So we need to pick it up. We need to do a baseline and 3-monthly weight as a minimum, so we can pick up those patients who have gained weight and then think about what we do. So weight gain is really important to identify, and it really affects people's confidence, self-esteem, and as I say, that sort of psychological adaptation to psychosis, it really plays into that sort of feeling of worthlessness. It's really hard to counter. It really is. And I think if we can identify it early and help patients look at their lifestyle, that is going to help. We need to think about changing their antipsychotic to one with less weight propensity to weight gain, and encourage physical activity. So in our team in the last year, we've invested in a health instructor, and he does sort of personal, like sort of individual sessions with patients in the gym, and he does group sessions, and that's really fantastic. And we look at weight. We don't focus just on weight, because we don't want people to become obsessed with weight. But we look also at his interventions have not only improved people's sort of weight gain, but it's helped improve their overall well-being, which I think is really important. And we're delighted that we've been able to invest in a health instructor. And then finally, diabetes. Please remember to check it. HbA1c is a good parameter for the previous 3 months of glucose control. And if their HbA1c is between 42 and 48, you know they're in that pre-diabetic range, and you can intervene then. So if they're on olanzapine, you need to stop it. If they're on clozapine, that's more difficult because the benefits of clozapine outweigh, I think, the advantages of stopping it. Give them advice about cutting out sugary drinks, etc., eating more healthily. If the HbA1c is over 48, then that's sort of diagnostic of diabetes. You want to then get on the phone to the GP and discuss it about starting something like metformin. There is also some evidence that metformin can help in the pre-diabetic range. And I think there's more studies looking at this, what we can do to sort of help people prevent the onset of diabetes in that pre-diabetic range. Finally, sexual dysfunction. It is one of the commonest reasons for people stopping antipsychotics, and it affects about half our population. So make sure you ask about it. That's the first thing. So care coordinators and the medics, please do ask about sexual dysfunction, because patients often are too embarrassed to talk about it and bring it up. And it is important because we can look at what can we do to improve it. So we can move them from, if they've got hyperprolactinemia, we can move them to an antipsychotic with less propensity to hyperprolactinemia. If the sexual dysfunction is very distressing for them and it's not medication related, you may want to consider prescribing something like sildenafil. Okay, so that's really physical health in a nutshell. I'm sorry, it's a whistle-stop tour. I just want to finish with the ugly, the anti-psychiatry movement. So I don't know if any of you have engaged with some of the people in the anti-psychiatry movement. It was really born out of sort of the 60s, Lang cells, etc., where, you know, psychiatry was challenged, and rightly so. But it has actually developed into very anti-psychiatry, anti-medication rhetoric, which actually creates fear and I think perpetuates stigma for our patients. And the important thing is to, I think, say is try, if you're on social media, don't engage with sort of anti-psychiatry rhetoric, because it's a battle you're never going to win. So I would sort of avoid that best we can. But be aware that our patients are going to probably see this when they go on the internet. So you're up against that kind of, you know, battle of sort of the negative facts that they're going to be told about medication. And so you just arm yourself with the evidence, know your facts about the medication. You know, you can quote statistics, etc., about how effective it can be, without being defensive. That's the important thing, I think, with this anti-psychiatry movement, is not to be defensive. And then finally, the final ugly, those of us working in psychiatry just know how difficult it is dealing with our patients who continually use substances. And I said a Sisyphean task. I mean, Sisyphus, you'll probably know, is a sort of a character from Greek mythology. He was the king of Ephyra, and he had dodged death twice, and I think Zeus had punished him to this by telling him that he had to roll this huge rock up a hill, and every time he got to the near top of the hill, the rock would fall down again, and he'd have to do it again and again through all eternity. And to be honest, it can feel a bit like that with some of our patients who continually abuse substances, you feel you're sort of making some progress, and then they go on a drug binge, and as you sort of back down the hill starting again. But what I would say, don't lose hope. Patients do change, and we just need to keep giving them the facts and working with them. Remembering that we're a team, so it's all about integrated care, and we give care in a spirit of optimism and hope, and that's what recovery is really all about. Okay, so I'm going to finish there and hope that.
Well done.
Sorry, I went a bit over, didn't I?
That's quite all right, Erin. We started quite late, so we're aware that there's. Thank you so much. That's the first thing I want to say. And I don't know if everyone can do a virtual round of applause with their a little yellow applause hands that can come up. There you go. That's the nicer thing about doing it this way. I'm going to hand directly on to Rajiv, who is one of the clinical leads within the early intervention psychosis team. And Erin, that was really, really, really interesting. And I think we will have more questions and time. So we'll think about that towards the end. But I'll hand over to Rajiv, who's been looking at the questions in the chat alongside Susie, and we'll be able to hopefully take you through people's reflections and questions. Thank you so much.
Thanks a lot, Rachel. I'll come straight into the question. Thanks a lot, Erin, for the talk. Fantastic talk. I myself have a lot of questions, actually. That's the advantage of doing this, hosting questions. I get to ask the questions first. But there was some excellent discussion in the chat box as well. I thought a couple of things before. I thought I'll just there was a point about depots, and I think need to stop discussing depots as something that is punitive rather than a positive choice like we do with contraception. I think excellent point that I think, like you said, a lot of people kind of think that depot is a punitive option, and that was what was taught to us, depots for people who don't take medications kind of thing. But I think a lot of the people given the choice, they'd rather take one injection a month rather than taking a tablet every day. It's so convenient. And with the second generation antipsychotics, they are, the side effects profile as well is very, it's very attractive to quite a lot of the people. And I think I was quite surprised that 1% is what you said, compared to, I think, probably half of my patients in Glasgow, at least the north and east of Glasgow, are prefer a depot compared to oral medications, which is great. A couple of questions which I thought was, I'll start off with my question: how long to monitor after stopping an antipsychotic? So you said 12 to 24 months is what NICE guidelines suggest after a first episode of psychosis. How long should we keep monitoring if a patient decides to kind of come off the antipsychotic? How long do we monitor them, and what happens to them? I mean, do we? The main concern, I think, among psychiatrists is, do we then discharge them back to the GP? And obviously, community mental health is not going to take on a person who is not on medication. So how do we go about doing that? That'll be my first question.
Okay, so how long to monitor? Well, I would usually say at least 12 months. And we're in England, we're a 3-year service. So if I took somebody off after 12 months, I would monitor them for 12 months. And that might just be, the care coordinator might actually not need, maybe start seeing them for the 6 month, and then they just move to what we call care support, where they just see me. If they haven't had any breakthrough symptoms in those 12 months, and they've made a full functional and sort of symptomatic recovery, then I would discuss discharging them back to the GP with a really robust plan for the GP. And I think that's the important thing, because GPs are quite nervous about psychosis and antipsychotics. So I put a very robust contingency plan saying, if the patient has a stay in well plan plan. They're well invested in their recovery. They know what the early warning signs are, but we'll give them to the GP. If they start having these warning signs, you may want to restart them on the medication they were previously on. If their symptoms continue, you will want to re-refer them back into secondary care. So that's what I would suggest. I would say that the majority of people who are going to relapse will probably do it in that 12 months after stopping antipsychotics. But remember, there's 15% of people who don't ever need to take any more antipsychotics. They have one episode of psychosis, they make full recovery, they never need to go back. So we need to identify or help identify those patients so that we're not saying patients need to be on lifelong antipsychotics. And can I just say one thing about, I audited my patients that I discharged to GP. A lot of them are referred back in, but they're getting back in really quickly. So when they do have a relapse, and what's lovely is many of them are staying out of services for a long time. So, 3 to 5 years. So I don't think you have to automatically step them down to CMHT, and particularly if they're off antipsychotic medication. Yeah.
It's a related question. Monitoring question, is that after the 12 to 24 year period? I suspect that question is about stopping the medication, and then when do you actually stop? Is it 12 months or 24 months? And how long after that? I think that's the question. It's related to the same question that I just asked. So
yeah, and I think the important thing is to tailor to the patient. If they've got good prognostic factors, it'll be more towards the 12 months per prognostic, more towards the 24 months.
And would you also consider, say, the risks involved in the first episode and things like that? Say, for example, if the risks were quite significant, then you would rather that the person is on the medication. Yeah. So, okay.
Yeah, absolutely.
And see, when you taper off the medications, again, I'm going on asking, when you taper off the medications, when you decide to stop the medication, is there any regimen that you think? I mean, when it's a depot, it's very easy, just stop the depot, and I'm hoping the drug will kind of go out over the next 5 months or so. Do you follow any particular regimen to kind of taper off the medication?
Sort of, again, I tailor that to the patient. I mean, some patients are just desperate to get off it as quickly as possible, and in order to prevent them just stopping it, if they're on oral, I would probably speed it up. Ideally, I would like to reduce it in 3 months, like an increment every 3 months. So my ideal would be, and we're lucky because we have 3 years, in that second year, weaning them off, which then gives us 12 months to monitor and see if they're going to relapse. But I know you don't have that sort of luxury of doing that. So I think you're going to have to take a pragmatic decision, but I would do it conservatively. If you're doing it with depots, I just space it out, so say if they're monthly, maybe go to, 5 weekly, 6 weekly, that sort of thing, and see if they get any sort of breakthrough symptoms on those, towards the end of, say, on the 6th or 7th week, they might say, oh, I just don't feel so good. I'm not ready to reduce it down yet. Yeah.
There was one more question. Just I'm just going through the question because it's in a chat. It's getting drowned in a number of other chat points. So how often should physical health checks be conducted on someone on long-term clozapine that is much longer than 2 years? That has been answered by one of the pharmacy leads. I think at least annually there are national standards if you Google it. Okay, that's been answered. There was another question which I thought was going. I need to. Oh yeah, this one. Need to explore what the sexual dysfunction issue is and how it's changed. Sexual function is also very psychologically influenced too. So yeah, I think that's more of a reflection rather than a question. I don't think there's anything else. Susie, sorry, you're on mute.
Sorry, Rajiv, there was a question about clozapine use in older people.
Oh, I can see that.
Can we just ask Erin, are you able to stop sharing your screen now so we can see your lovely face in slightly bigger form? Thank you, Rajiv. Thanks very much.
Oh, I missed that point, Susie. Sorry.
I think it was just clozapine in the older adult. When can it be used? Is the question.
Okay. I'm probably not the best person to answer that. Although we do now, our early intervention service has now gone up to 65 years. So yeah. So I haven't got much experience of using clozapine in older adults. I don't think that there's any reason why not. I just think that if someone's going to develop treatment-resistant schizophrenia, they probably would do it, develop it much sooner, or it should be identified much sooner than in older adults.
Oh, there was another question. How often do you guys use home initiation of clozapine? Down there?
Yeah, I mean, pretty much most of our initiation is home initiation, because I'm sure you're the same in Scotland, really, really difficult to get beds. You certainly wouldn't get a bed for just clozapine initiation. If we admit somebody who is acutely psychotic and while they're in, we've tried 2 different antipsychotics, then I'll move them on to clozapine while they're an inpatient. And my team are always very happy for that, because you can feel their sort of tension when I say we want to start somebody else in clozapine. They're great, but they know it is hard work, because you've got to be doing those pre and post OBS throughout the day. And yeah, it is really difficult. And particularly if someone is living on their own, I wouldn't initiate somebody who lives on their own. So we have to move them to somewhere where, like a respite unit, where there are staff 24/7. So it is really challenging. We work with our local home treatment team. So early intervention, our team will do the morning OBS and administration of the clozapine, and then home treatment do the evening OBS. And we just have to make sure that we liaise really well with each other.
No, that home community initiation is really challenging, as services in CMHTs, the community mental health teams, aren't set up to support it, and particularly in rural areas. I suppose it's very different in city, urban areas, but in rural areas where you have to kind of travel quite a bit to kind of get to the person, it's quite challenging, I suppose, from a Scottish perspective. So
so for rural areas, I just wonder, I mean, what is it like to have, are there any respite units, or, because it's really hard to sell clozapine if you're saying, I have to admit you to hospital. That's really difficult. I think that obviously would put a lot of patients off. So I think that's something that really needs to be thought about, whether there was a unit that they could come, for the first 2 or 3 weeks. I don't know, what's it like getting beds in Scotland, inpatient beds?
No, getting inpatient beds is impossible just for treatment.
Yeah.
But when I say Scotland, I can talk about Glasgow, definitely. I mean, I get emails every day saying there are no beds. There are no beds. Can people discharge people? So no, beds situation is a very difficult thing, and clozapine initiation not necessarily the choice unless the person is really unwell, and then they come in as part of them being really unwell. So yeah, no, I was wondering. I was just going through the further questions.
And just to let you know, we've got about 2 minutes left for questions.
All right, so one more question. Just wondering, would you ever prescribe, say, aripiprazole with a short-term benzodiazepines to reduce agitation rather than starting first off on olanzapine?
I do that a lot, actually. I think it's really, really good. The important thing is to bring the stress down. You can bring the stress down, we're going to improve the psychosis. And aripiprazole, we know, is really got good side effect profile, but not so good at bringing down the stress, the initial stress. So, and it can cause a bit of sleep disturbance. So I do that a lot. Yes, short-term benzos. Particularly sort of in the evening, and that's really effective, actually. And particularly when if you're moving someone from olanzapine to aripiprazole, you just need to warn them that they probably will have some sleep disturbance, and if it's really severe to the point that you're worried they might get some breakthrough psychotic symptoms, you might want to prescribe short-term, benzos or zopiclone.
Okay, I think that's I work in older community mental health teams, and one of my patients had conventional clozapine, but this was very low dose, and an admission was arranged to monitor this in the first instance. So that's just a comment. It's like I said, because we had to kind of move this into this this approach. The chat is getting drowned within the, or the questions are getting drowned within the chat. I think that's it, Rachel. If I can pass the thing back to you. Thanks a
So
lot.
can I just answer the very last question about ECG monitoring, particularly if you're on combination antipsychotic and an SSRI or an antidepressant? I mean, we just take the pragmatic view of annual ECG monitoring, just looking at the QTC. I'm not an ECG expert at all, but that's kind of what we've adopted. I'll shut up.
Don't ever stop talking. That's the thing. So I have so much to say that's not going to fit into the next 2 minutes. I would like to thank everybody who is here today for bearing with us around the technical hitches that we had in getting Erin into the very forum that she was presenting at. I'd also like to thank everybody for putting all the comments and the questions in the chat. There's loads of comments there that I think we need to pick up on. I would like to thank Erin, which we will do. We'll pick up on those comments and I'm going to come back to that in just one moment. I'd like to thank Dr. Erin Turner for that really, really fabulous overview and prompting all that discussion that's happened just then. And if we could have given you another, the rest of the day, I think we would still be here. I would like to thank Susie and Rajiv and Ashley for monitoring the chat and for looking at the questions and for being able to reflect some of that back during this session. I'd like to thank Sarah and Deb and Andra, who are behind the scenes and who managed to make 220 people move from one link to another link within a matter of minutes and found solutions to things that I did not think were possible. So I'd really like to thank them as well. So thank you all for being here today. There is something that I would like to ask you all to put in the chat. I have so many more questions and comments and so on. If you would be interested in a follow-up session or a workshop that is around physical health and psychosis, picking up on some of the strands that we saw today and picking up on some of the issues that we are being reflected in the chat, please do say yes, you'd be interested in the chat. If the other thing that we would really like is if you could give us a little bit of feedback in the chat. We can see that people are already saying thanks for a great session. So I would really like to hear any comments that you've got. And finally, I'll ask a member of the team to put in the chat what we would normally put as the last slide, which is about our website and how to email us. Great, we've got lots of people there. Erin, I think we might have created a job for life for you to be up in Scotland talking through the issues around physical health care and psychosis, and again where it links to other programs and other integrated care pathways. I think that's another point that we could have picked up today really strongly. Thank you all very, very much. I'm aware that it's 11 o'clock and many of you will have somewhere else to be, so I'd just like to thank you all once again for your time and your input, and especially to you, Erin. Thank you so much for this morning. Okay, goodbye everybody. Thanks so much.